So I'll be talking on primary angle closure glaucoma and cataract, dealing with dilemma. So we know what angle closure glaucoma is. The pathomechanism of angle closure has lens-induced and exaggerated lens vault, which is now confirmed also. So we have to see the role of lens. So the crystalline lens has a major role in primary angle closure due to pupillary block and exacerbation of the peripheral iris crowding. So it has been seen that in these eyes there are thickened lens which are positioned relatively anteriorly. So that is why the lens is thick and they are anteriorly also. So that is why there is a very crowded anterior chamber as well as the crowding of the angles leading to closure. So therefore cataract extraction is beneficial in eyes with angle closure disease in cases where they have increased lens thickness, increased lens vault. And because of after the cataract surgery, it has been noted that there is an increase in not only increase in the anterior chamber depth, but also there is increase basically in the angle and the iridotrabecular contact area. So because the lens thickness that we are actually the cataractous lens that we are taking out are nearly between 4.5 to 5 mm versus a thin lens that we are placing, which is an average 1 mm lens. So that is why that area, that crowding has gone. So this is just a simplified outline wherein if a patient of angle closure glaucoma has cataract, so depending upon the stage of the glaucoma, whether the patient has mild to moderate glaucoma versus advanced. So if the patient is more towards mild side and the patient has a target IOP which is achieved, okay, so we would preferably do a phaco in that patient. If the target IOP is not achieved, then we can go for phaco with MIGS like GSL, BANG, ECP. However, if the disease is more towards moderate to advanced stage, we would like to go ahead and do a combined surgery or a stage surgery depending on the patient's eye status. So I would be coming to it. So what are the important things that we need to keep in mind in these patients? So in these patients, we know that these patients are smaller eyes, hypermetropic, smaller narrow palpebral fissures, shallow anterior chambers. They do have posterior synechiae, due to which there is poor intraoperative mydriasis. There is difficulty in dilating these patients because of the posterior synechiae. They usually have compromised in the endothelium because of the attacks that they have, the angle closure attacks, and also because of the age. And therefore all these high risk cases, there is a high chance of intraoperative and postoperative complications, and therefore these eyes should be done by experienced surgeon. So there are various complications like corneal edema. If the pressures IOP of these patients should be controlled very well before you take the patient for cataract surgery. Never enter a eye which is high which has a high IOP, because there is a high risk of suprachoroidal hemorrhage in such eyes. So if lower the IOP, if there is a peripheral iridocorneal apposition, there's a high, in these cases there are high chances of iris prolapse, and because of which there can be a wound side DMD leading to a complete DMD. There can be because of the increased convexity, capsular rexus extension can happen, and once you take out that thick nucleus, these bags are usually floppy. So while taking out the last piece, many a times it so have happened that there is a PCR. So that is very important, and also the risk of suprachoroidal hemorrhage is also there. So the first and foremost thing is enter a soft eye which is the IOP is controlled. Second and most important thing is use of a very high viscosity viscoelastic to deepen the anterior chamber, and then we also have to use viscoat, basically a viscocohesive, to coat the endothelium, because these eyes are high risk. That is, we can follow the soft shell technique. We should avoid small rexes in these eyes because we want the nucleus to come out. So smaller the rexes, more the manipulation and more the inflammation and more the risk of complication. And there is a high risk of floppy capsular bags. So therefore we have to use very low phaco parameters. This is known as slow phaco. So this is just a surgical video wherein we can see that the patient is a case of angle closure glaucoma who is non-dilating and very shallow anterior chamber, nearly 0.9 mm. So we are using the help of iris hooks to dilate the eye, and then we are doing a capsular rexus. So once capsular rexus is done, you have to do a good hydrodissection and delineation. And at this point of time, you should remember that in hydrodissection, you don't have to do a very vigorous hydro, because again, if you do a lot of hydro, the entire blob of nucleus can just come up and lead to a sudden rise in IOP. So after putting the lens, the important thing that we should know is that whenever in very shallow ACs, we try and suture the wound because there might be leak. So if you think that the wound is leaking, better to suture it. So we have seen that in cases of after angle closure glaucoma, after the phacoemulsification, not only the anterior chamber depth has opened up, the iridotubercular contact has also improved after the surgery. So this is the preoperative ASOCT, and this is the post-op ASOCT, where you can see that there is a widening of the angle also. The second is to do a staged operation. So what is staged phaco? So the stage is basically we do a phacoemulsification first, followed by trabeculectomy. So we all know that glaucoma filtering surgery, that is trabeculectomy, in patients with angle closure glaucoma, they have been proved to be associated with multiple surgical interventions, especially because of shallowing of the AC which happens, and to reform the AC and use of steroids, the cataractogenesis, there's a lot of cataractogenesis which happens, and just after within first year of trabeculectomy, we have seen that the rate of cataract progression is higher in these patients. So therefore, in patients who have very shallow anterior chamber, we can go ahead and do a initial cataract surgery in such patients. So in my opinion, PACG patients who have very dense cataract or who have posterior sinus in which a combined surgery cannot be done, or patients who can regularly follow up, who understand this thing of stage surgery, because again combined surgery has a lot of inflammation, and doing a stage surgery can help us achieve the target IOP. So if you are doing a stage surgery, we need to combine the stage surgery with a MIG surgery. So phacoemulsification alone may not effectively reduce the IOP to target levels in eyes where the trabecular meshwork remains occluded by peripheral anterior synechiae despite the anterior chamber deepening. So that is why we can use goniosynechrolysis, wherein we are stripping off the peripheral anterior synechiae from the angle wall to restore the trabecular outflow. So this is just a small video wherein after doing a phacoemulsification, we deepen the anterior chamber with a viscocohesive viscoelastic, then put the Swan-Jacob direct lens, gonio lens, and we can use a 23 gauge Healon cannula itself, or we can use a iris spatula, and we can just see that how just gentle sweeping leads to the opening of this broad base synechiae. And once this synechiae is opened up, we can go ahead and do a bang also in these eyes, wherein we can strip off the abnormal trabecular meshwork. Here, we can see there's basically the arrow is showing how that strip of the trabecular meshwork has come out, and we just cut it and do a routine irrigation and aspiration. So we have seen that the phaco with goniosynechrolysis have significant reduction in IOP, and in our series we have seen that the strongest predictor for decrease in IOP post surgery was the higher baseline IOP, lens thickness to axial length ratio, and patients who are having a higher lens fault. All these patients showed a better reduction in IOP. Then there's another procedure known as phaco-endocyclophotocoagulation. So again, endocyclophotocoagulation, one should know that the power being used is 0.2 watt, which is 1/10 the power of the DLCP that we are normally using, and that's why the side effect profile and the safety profile is much better. So if the patient cannot go ahead for a combined surgery, then we can do a phaco ECP in such patients. So in this, again, after doing a routine phacoemulsification, after putting the lens, we just need to basically form the sulcus. We put a very high viscosity viscoelastic into the sulcus area after putting the lens, and not do INA, just put the viscoelastic and then put the 20 gauge probe into the eye, and then you can see the ciliary processes like finger-like projections, and aim each of the eye, and the end point is whitening of these ciliary processes. So initially they look brown, and as we are doing a photocyclocoagulation, they are getting white. So this can be one of the procedures. So again, it can be used in patients who have mild to moderate PACG with cataract, mild to moderate PACG in which the IOP is not achieved, and patients who are undergoing stage surgery. We need something to control the IOPs. And then is phacotrabeculectomy. So phacotrabeculectomy we reserve for patients who have PACG with cataract, and basically advanced PACG with uncontrolled IOP, and moderate to advanced PACG also we would like to do a phacotrabeculectomies. So in phacotrabeculectomy, As Dr. Shalini has shown very beautifully, the important thing in this is that the rhexis should be of a adequate size. It should not be a small rhexis, otherwise it leads to a lot of manipulation, and more the manipulation, more is the inflammation. Higher the inflammation, higher the risk of the failure of the surgery. And after this, we do a hydrodissection, and then we do a routine phacoemulsification, and this is a two-site surgery. And then we do a routine trabeculectomy. What important thing is that depending on the eye, we can use a releasable suture, and we always have to suture the side port, which normally in routine phaco we don't suture the side port, but in this size you have to suture it. Otherwise the angle is shallow and it tends to lead to the failure of the surgery. So at the end, I would like to say that management of patients of PACG with cataract depends on the stage of the disease, whether the target IOP is achieved or not, the density of the cataract, the presence of posterior synechiae, and other risk factors. So treatment of each patient is individualized. One size doesn't fit all. Likewise, one surgery will not fit all. So patient, and lastly, but not the least, patient counseling for lifelong follow-up is important, because after phaco, many patients think that surgery is done, they stop the medications. So this is one important thing that has to be taught to the patients. And lastly, experienced hand is required in such diseased eyes. Thank you.